All right. Hi, everyone. My name is Megan Pollier. I'm the Clinic Partnership Manager here at MAVEN Project. Thank you all for joining us today, and our friends over at Bart's Altadonna Community Health Center for hosting today's session, which is titled Successful Management of Gout in the Primary Care Setting by Dr. Robert Goldfien. Dr. Goldfien worked as a rheumatologist at Kaiser Permanente for over 28 years, excuse me. In addition to his clinical practice, he held roles as Chief of Medicine at Kaiser Richmond, Chief of Rheumatology for Kaiser East Bay, and Chair of Rheumatology for the Permanente Medical Group. He is currently consulting in rheumatology at 2 community clinics in San Francisco and Marin County, California, and he has a special interest in inflammatory arthritis and the management of gout. So we're so happy to have Dr. Goldfien with us today, and I will go ahead and pass it over to you.
Thank you, Megan. Can you hear me?
I can hear you.
Okay. So my talk today is about gout and managing gout in primary care. It is a longstanding interest of mine, in part because I did a lot of primary care as well as rheumatology. And in doing that, I learned a lot about managing chronic conditions, and I realized that gout is really similar to other things that you manage in primary care. So I'm hoping to give you some useful information and some actually specific guidelines on how to manage gout successfully. I have no disclosures. This is the accreditation information you heard. So learning objectives. I'd like at the end of this talk for you to understand, gout and why its prevalence has been increased and the risk factors for gout. In particular, recognize gout as a chronic metabolic disorder rather than thinking of it as a rheumatologic disease. I want to be able to distinguish between our way of treating acute gout, which is how it presents, from the management of chronic gout and hyperuricemia. And I'd like you to think of having a target-oriented approach to managing serum uric acid. So first of all, what is gout? Well, gout is a chronic condition characterized by hyperuricemia that leads to an accumulation of sodium uric crystals in joints and in tissues. However, clinically, it presents typically as an acute arthritis, usually monoarthritis, and it can be self-limited. It can go away by itself in a few days, although we typically will try to treat it. It's most common in the first metatarsophalangeal joint, but it also occurs in other joints, commonly the midfoot, the ankle, sometimes other joints. And in many cases, over a period of months to years, the frequency and duration of gout flares increases as the burden of uric acid crystals increases. In severe cases, which we can see in California sometimes, tophi may become evident as subcutaneous nodules around the joints and tendons. So gout is the most common inflammatory arthritis in men, and it occurs in men with a ratio of about 3-to-1 versus women. Contrast that with rheumatoid arthritis, which is about 3 times more common in women than men. It is something that increases in terms of incidence with age, and the incidence does vary worldwide. In the US, there's typically been a higher rate of gout in some Asian populations. Notably, however, the incidence of gout has increased a lot in women and in African American men. It's actually more common, or at least more prevalent in African Americans now than in white populations. And the reasons for that have to do with comorbidities, which I'll talk about in a moment. The incidence of gout increased a lot from about the 1980s or 90s through about the 2010s. The incidence of gout in the US increased 2 to 3-fold. And the way to understand that is to look at gout's comorbidities, and they're listed here, the 3 of them at least. Hypertension is seen in about 75% of people with gout, diabetes in about 30%, and CKD stage 3 or worse in about 30%. This has been not only my experience in my own clinic, but there are published data on this that pretty much show those numbers as being consistent. There's a reason for these comorbidities, and they primarily have to do with uric acid excretion. So in diabetes, insulin resistance leads to reduced excretion of uric acid. And of course, so does renal insufficiency with decreased GFR. So these are really common, and you can expect to see them frequently when you see gout patients. Uh, so diet inevitably comes up in every visit about gout with my patients. And typically it's my patient that brings up the diet. And, there's a good reason that diet is considered important in gout and that people worry about it and patients think about it. I mean, beyond the fact that, we like to think that we can get ourselves healthier by eating better, it's clear that some foods are associated with gout. And primarily those are foods that elevate serum uric acid. So we know that shellfish or seafood, organ meats, and alcohol can increase uric acid levels temporarily or transiently. High fructose corn syrup is one that sometimes rides under the radar, but it's another reason to recommend your patients don't drink sugary soft drinks. Legumes are high in uric acid, but I wrote here, I don't tell people not to eat legumes because I don't think there's any data that actually has tied them to gout attacks as opposed to just having uric acid in them. And they're healthy, unlike the things listed above, or at least some of them. Foods that lower uric acid, primarily dairy, has been recognized as something that can lower uric acid levels. However, importantly, dietary intervention typically has a limited effect on gout and serum uric acid. It's fine to do that, but the best way to think about gout and diet is that diet is really a trigger of a gout flare, and it's not really the cause of gout in most people. So anything that perturbs the level of uric acid in the blood can trigger a gout attack. And of course, that's why people associate it with gout. But again, thinking of it as a trigger and something to have people be aware of. I tell people if they want to drink a few beers a week, that's probably fine, but just don't drink them all at the same time, and you won't get a gout attack. So diet's important, but we're not going to focus on that in terms of management. Diagnosing gout. Well, I think to start with, gout is often ends up being a clinical diagnosis. Obviously, identifying sodium urate crystals in the joints is a definitive way of diagnosing gout. It's not always practical, and that can be for many reasons, but including that sometimes it's not so easy to get fluid out of a metatarsophalangeal joint. Also, patients aren't really happy to have you stick a needle in them if you don't have to. So it's often a clinical diagnosis. The serum uric acid is almost always high, and it's almost always high, especially in untreated gout. So if you see someone you think might have gout and they're not on treatment, getting a uric acid level is important, and it's typically going to be high. If you think someone might have gout, maybe not sure from the clinical presentation, but the uric acid level is 4 or 4.5, it's probably not gout in my experience. It's sometimes useful to look for a typical pattern, which is an acute episodic arthritis. It usually comes on relatively quickly and becomes severe. And the typical joints I mentioned, the big toe, the midfoot, and the ankle are the most common places. Notably for gout, any kind of arthritis can sometimes fluctuate in intensity, but with gout, typically the story is that it goes away completely. So between gout flares, the patient has no symptoms, and that's characteristic of gout. Radiographs can be helpful, but like radiographs in rheumatoid arthritis, if the condition is recent onset or not severe, plain radiographs are often normal. If they are abnormal, it's usually someone who's had it for a long time, and you might see erosions on the joints, in involved joints. I wrote ultrasound and CT primarily just to say there are actually ultrasound and CT findings characteristic of gout, but they're probably not practical and maybe not be available for many of us, especially in clinics that don't have a lot of specialists. But ultrasound can diagnose gout through a particular thing called a double contour effect around the joint. CT, there's a type of CT called dual energy CT that can show sodium urate deposits. When I was at Kaiser, I couldn't convince my radiologist to start doing that, so I just didn't try to do it. Family history is something worth checking. It's fairly common for gout to run in families. I typically find a young person with gout, especially, often has a family history. You can't really diagnose it based on that, but it's helpful in terms of pointing towards gout. Comorbidities is important. Again, chronic kidney disease, hypertension, and diabetes are all commonly associated with gout. And sometimes that makes treatment a little more difficult, but we'll talk about that. Triggering events, yes. Typically, it'll be some kind of food or sometimes alcohol. Impact exercises, I've seen that trigger gout attacks in the big toe. So it's often a clinical diagnosis, but if there's a typical picture and you feel comfortable that that might be gout, we'll talk about treatment, but I would typically go ahead and just treat as though it's gout at that point and then do what you need to do to document the diagnosis. And I just want to reemphasize, gout is rare. It's in untreated patients with a serum uric acid less than about 6 or 6.5. That's about the level where uric acid becomes insoluble in plasma. So it really has to be that high, at least a lot of the time, for people to develop gout. And level can fluctuate over time and with flares, but not by huge amounts. Okay, getting to treatment. There's a couple principles about treatment especially for acute gout. First, I recommend treating early and aggressively. The more inflammation gathers in the joints and builds up in the joints, the harder it is to calm it down and get rid of it. So as soon as someone starts having the symptoms, I tell my patients, as soon as you feel that toe start to tingle or feel funny, go ahead and start your treatment. And I say aggressively, meaning typically, if you're going to use NSAIDs, which are a good option for most people, you want to start with a high dose, and then you can sort of taper over time as the symptoms get better. NSAIDs, colchicine, oral steroids are all effective to treat gout, depending on the situation. Ice, in this case, means ice from the freezer. And it's been shown applying ice on a gouty joint can actually help. Now, the treatment options may be limited by comorbidities. If someone has diabetes, you know, you have to be a little careful about using steroids, even though it's possible and you can do it. CKD makes it a little dicier using NSAIDs and colchicine. But again, it doesn't rule them out entirely. You just have to take those into consideration and monitor carefully. One pitfall in treating gout that I saw many times over the years is stopping the treatment too soon. If you've got a very inflamed joint and you treat someone for 2 or 3 days and it's a lot better and then stop, it's not uncommon for the symptoms to come back. And it can sort of get a little bit refractory at that point. So I definitely tell people to treat until the symptoms are completely gone if possible before stopping treatment. And again, the other thing is that because it gets worse over time and sometimes is undertreated, you do see people with frequent or persistent symptoms, and sometimes they just require longer treatment. And in my case as a rheumatologist, this might have come up with someone who's had recurrent attacks in the last few weeks and it keeps coming back. And I end up putting them on steroids and tapering it over 2 to 2.5 weeks in some cases. to make sure that the symptoms are completely controlled. NSAIDs are the sort of most common treatment for acute gout. Indomethacin has been the traditional NSAID used, and it may be a little stronger than some other NSAIDs, but other NSAIDs work fine. People have often have at home things like ibuprofen or naproxen. Again, though, it's important to use high doses to start with. So if someone's on ibuprofen, I might tell them to take, 800 milligrams 3 times a day for a day or two, and then cut down when they're feeling better. Low doses just aren't strong enough to really shut off the inflammation in an acute gout attack. Um, Sometimes I use a shorter acting NSAID because I think that it may have a more rapid effect, but that's a minor point. Any NSAID that the patient tolerates can be effective. Okay. Prednisone. So oral prednisone is highly effective for acute gout. Um, and it can be a good choice if someone has chronic kidney disease or if NSAIDs aren't tolerated, or as I alluded to earlier, if the initial treatments are not effective, switching someone over to prednisone is often a very good choice and almost always works well. When I use prednisone for gout, I usually start with 40 milligrams. I don't think you'll see that in any guideline anywhere. You might, but initial cortisone or prednisone doses for arthritis are a little bit one of these things that people just sort of develop a habit of how they do it, and it's not so much guided by evidence as by what people are used to doing. But 40 milligrams, in my experience, usually is high enough. And I would typically give someone 40 milligrams for 3 to 4 days and then taper it gradually over the next 7 to 10 days. Intra-articular steroids, I mentioned, they actually are quite effective. And if someone has gout in a knee joint, for example, and you don't want to put them on systemic treatment, and a knee injection with triamcinolone or methylprednisolone will also be very effective. I don't tend to use this for small joints, however, just due to the discomfort of sticking needles in an inflamed joint. So all of these treatments can work, and your choice of treating someone is going to depend on their comorbidities, what they've already tried, what they've tolerated before, and with using high doses and persisting a little longer in the treatment, it's usually effective. Colchicine is another agent that's been used. Interestingly, colchicine, having been used for many, many, many years, maybe centuries, was actually approved by the FDA in 2010. And based on a study that looked at the dosage listed in the next bullet point, the FDA recommends using 2 tablets of 0.6 milligrams at the onset of symptoms, and then 1 tablet an hour later in the absence of CKD, significant CKD. You can also continue to use it to 0.6 BID for the next 2 to 3 days. And that's fairly effective. I don't think it's better than the other treatments, but it's something you can use in someone with, let's say, hypertension or chronic kidney disease, as long as you don't keep doing it for a long period of time. I will just note that the old regimen that I grew up learning, which was to give someone 1 tablet per hour, every hour up to 6 tablets, um, isn't any more effective than the one recommended by the FDA now, but there's a very high rate of GI side effects which limit the effectiveness. So I just abandoned that and used the FDA recommendation. It is good to avoid colchicine in patients with advanced CKD. It can be pretty toxic in that setting. I think with CKD3, modest doses are fine, and I use them all the time. Okay, so I want to shift now to talking about treatment of chronic gout and hyperuricemia. And I hope that this is the part of the talk which will give you a little bit of a sense that you can manage this in primary care. So I want to emphasize gout is a chronic metabolic disease. I like to say dressed up as arthritis. the management of gout, the successful management, therefore requires a systematic target-directed approach to lower uric acid and monitoring of the serum uric acid. The best analogy for this, and one I sometimes will use for my patients because they can understand it, is to compare it to treating hyperlipidemia and coronary disease. So we don't wait till someone has a heart attack and then treat them with thrombolytic agents. If we can, what we try to do is we try to treat the underlying metabolic problem, in this case, hyperlipidemia, and then we prevent heart attacks. And so in a similar way, if you treat hyperuricemia, then at least ultimately, rather than waiting for someone to have a gout attack and treat that, we can prevent the gout attacks by treating the underlying problem. It's really quite analogous, and it's something you can explain to patients so that they understand the point of the urate lowering treatment and why they have to stay on it long term. Some general principles. This is just to reiterate, the key to managing gout is keeping the serum uric acid level under 6. 6 is a target we use because that's about the solubility point of uric acid in blood. So that's usually used as a target for the treatment. Urate lowering therapy is very effective and can achieve that target dose in almost all patients if escalated appropriately. It was my experience that the treatment of hyperuricemia for many years was a little bit like put someone on some allopurinol and that's all you do. And really not effectively titrating a dose or monitoring, which is otherwise you really can't know if you're giving the appropriate dose. One of the complications of treating gout, which I think is unfortunate and probably the only thing that makes it harder than treating hyperlipidemia, is that you can actually precipitate more gout flares when you treat someone. Initially, lowering the uric acid level with drugs actually can cause more flares. And it's been documented that people on treatment with urate lowering drugs actually, on average, have slightly more gout flares over the next 6 months or so. So you have to be prepared for this, and the patient has to be prepared for it, because otherwise what typically can happen is you can put someone on medicine like allopurinol, and 2 weeks later they get a gout attack, and they're naturally going to conclude that this treatment isn't working. So that's really important to get to tell your patients that going on treatment doesn't immediately get rid of gout. They have to be prepared to have some flares, maybe not more, but definitely possibly some, until clearance of the urate crystals from the joints has occurred. And that is something that takes place over months to a couple of years in most people. Medication non-adherence in urate lowering treatment is extremely common. And actually, there have been studies that show that it's more common than chronic conditions like hypertension and hyperlipidemia. And that means that if you want to manage it, you have to be able to monitor the serum uric acid level and make sure the patient's still on the treatment. And the first line treatment for gout these days, it's been this way for a while, is allopurinol. Many people have gout because of underexcretion of uric acid rather than overproduction. But over the years, it's become, I think, fairly clear and accepted that allopurinol just works really well for most people. It's easy to take, and it doesn't have a lot of drug interactions. The one area where you have to be careful with allopurinol is this HLA-B5801, and that has to do with this allopurinol hypersensitivity syndrome. This is kind of the thing that scares a lot of people about taking allopurinol, is that, a very, very small percentage of patients can get a severe and potentially fatal allergy that looks like Stevens-Johnson syndrome, or something we now call DRESS syndrome, which is drug reaction with eosinophilia and systemic symptoms. It's a severe allergic response with fever, hepatitis, rash, and can be fatal if not recognized and treated. It usually occurs in the first several months of treatment. And interestingly, the risk is much higher in people who have this HLA gene called HLA-B5801. And you can test for this, and it's recommended in certain circumstances. In particular, there's a higher prevalence of this gene in Chinese population, Korean, Thai ancestry. They all have higher prevalence of B5801. The ACR currently recommends checking for this before starting someone on allopurinol if they're in one of these groups. Now, I'm going to say that I wouldn't necessarily avoid screening in other populations. It's conceivable that, the recommendation for that might change in the future. I don't know that it's any harm to screen your other patients for HLA-B5801. It is a marker for the severe allergic reaction, and you wouldn't want to treat someone with that gene. So before starting treatment, you would want to check a B5801 if your patient is one of these populations. Now, if you can't use allopurinol, or if occasionally allopurinol isn't well tolerated, and I say occasional, it's not common. Febuxostat is the other first-line drug for HLA-B5801 patients. Febuxostat also reduces uric acid production, but it's not a purine. So it doesn't look like allopurinol. It's a very effective drug. It's usually 40 milligrams once a day is enough of a dose. The reason it's not a first-line drug from my point of view is that it's very expensive and allopurinol is very effective and cheap. So I definitely use allopurinol almost always, unless someone's B5801 positive. Finally, if someone's going to get this reaction, usually they start feeling itching and rash or maybe fever. And it's good to warn people if they have any of those symptoms to go ahead and just stop the medicine right away. So to be a little more specific, what I tend to do is I'll typically start someone on allopurinol if they've had more than 1 or 2 episodes of gout. And I start them on a low dose of 100 milligrams of allopurinol per day. If someone has CKD4, maybe even CKD3, you could always start with 50. There's not a lot of evidence on this, but it's good to start with a low dose and then titrate up by usually 100 milligram increments over a period of weeks, and monitoring the serum uric acid as a guide. So I'll show you a protocol for how I do this, something you can use in your clinic if you want. The dose of allopurinol needs to be titrated to achieve a serum uric acid of less than 6. If you put someone on allopurinol and they have a uric acid of 9 and then it comes down to 8, that will not fix their gout. Even if it, it's nice to be on a lower dose, but it won't fix the gout because it won't clear the crystals out of the joints. So you do have to titrate the dose. And I mentioned febuxostat as a second-line drug. You usually start with 40 milligrams a day. I recommend using daily colchicine as what we call flare prophylaxis. So I said that people can have gout flares after starting allopurinol, after normalizing uric acid, and that situation can last, a year in some cases. So you can reduce the risk of flares by having someone stay on 0.6 milligrams of colchicine once a day, especially if they have a normal GFR. If they have a low GFR, you can still use colchicine, although I would say you could use it every other day or twice a week or something. Importantly, if you are treating someone with urate lowering treatment and they do get a gout flare, do not stop the allopurinol or the febuxostat, because that'll cause a sort of increased sort of fluctuation of the uric acid level, which can trigger more gout attacks. So the tendency patients often have is, well, when I get a gout flare, I go on my colchicine, and I stop my allopurinol. But you don't want them to do that. You want them to stay on it. So I said I had a protocol. What I'm going to show you is a protocol I used for a little sort of study I did in my clinic when I was at Kaiser. It and the idea behind this was we had chronic conditions programs, chronic disease management programs that were staffed by nurses and pharmacists for diabetes, hyperlipidemia, hypertension. And it occurred to me we could do the same thing for gout. So I set up a protocol using a pharmacist um, to uh, to manage hyperuricemia and gout in patients who were referred to me by my primary care colleagues. So this was the program. Uh, and the idea was that I set up a referral uh, system to refer people with gout to my clinic. And then I would put them through this protocol. If they were having a gout flare, I would treat it. If not, I would simply go straight to starting or titrating their uric acid lowering treatment. So for example, I would put them on 100 milligrams of allopurinol and wait 2 to 3 weeks, check their serum uric acid. And at that point, one of two things. If they weren't at goal, then I would loop back up and titrate up the urate lowering treatment and wait another 2 to 3 weeks and check it again. And I would keep doing that until the uric acid was less than 6. Once it was less than 6, I'd go to the bottom of the chart where it says check SUA. And if it goal, I would have them check it again at 3 months, I guess is what I would do. So 2 to 3 weeks to titrate. And once they're at goal, after 3 months, check it again. And if they were at goal, then we discharged them from the clinic. A word about the checking at 3 months. I recommend doing this. And the reason is that such a high percentage of people just end up stopping their medicine. So if you can get them in to check the uric acid level at 3 months, if the uric acid level has gone back up again, you can remind them to stay on the medicine. It's just a way of checking that someone's doing the treatment. So the next few slides show some of what we found in this clinic, just to give you an idea of how effective this was. This graph shows the initial starting uric acid level and the final uric acid level when the patient was discharged from the clinic or when 1 year had passed. There were, I think, 88 patients. So each of these sets of two bars, a red and a blue, represents one patient. And as you can see, the red bars, all, there are a couple of exceptions, but the red bars are almost all above 6. And the blue bars, about 80 or 85% of them are actually below 6. So this gives you a sense of how successful this protocol was at getting people to a normal uric acid level simply by having them increase their medicine a few times and check the uric acid level. This gives a little bit different way of looking at it, and I think I use it to emphasize sort of the real life problem with treating people. So if you look at the left side of this graph, and there's a green line that is at 6 milligrams per deciliter. All of the patients in this sample, which were selected randomly from my group, they all started out with a serum uric acid above 6. And they all came down initially, as you can see at the very beginning of the graph. Every single one of these drops because they went on urate lowering treatment. And then some of them stayed down below 6, but not uncommonly, you see them come up again and then down again. And this is reflecting the fact that it would come down, and then when I checked them again, they stopped their medication and it would go up again. And so we put them back on the treatment and it came down again. This is not unusual, as I sort of alluded to before. People have lots of reasons why they stop taking their medicine. But it's particularly, I think, common with gout because gout is episodic. And so if they go a few weeks or a month without having a gout attack, it's real easy for them to imagine that they're done. They don't need to treat anymore because they're fixed. So people will bounce around a little bit, but if you persist, you can keep most people at goal. This is another, I thought, interesting part of the study. I just plotted here what dose of allopurinol is required to get someone to a target uric acid level of less than 6. And what this shows is that, and these are not percentages, this is just number of patients. Um, it was relatively unusual for someone to be at goal with the allopurinol level of 100 milligrams per day. About probably a third of patients were at goal on 200, and about two-thirds by the time you get to a dose of 300. And then you see what happens at 450, 500. I would note that studies that have looked at allopurinol in the last maybe 10, 15 years, some of which compared allopurinol to febuxostat, have pretty much shown that if you put someone on 300 milligrams of allopurinol, there's about 65 or two-thirds percent, sorry, about two-thirds or 65% of them will be at goal on that dose. That's great, but it means that a third of people won't. And it means that if you stop at 300, a lot of people won't get to goal and won't get rid of their gout. I don't think I needed to give anyone more than 600 milligrams in this group. But the FDA has approved allopurinol to treat people in doses up to 800 milligrams per day. Okay, I'm going to do a couple quick cases, and then I can take questions. And these cases represent pretty typical scenarios in my practice. So this is a 47-year-old Chinese male. He's had 3 gout attacks in the last couple of years, and he's been told to avoid certain foods and to take colchicine if his gout flares occur. Review his chart. He's had a serum uric acid of 8.2 documented about 2 years ago. It hadn't been checked since then. His medical history is notable for type 2 diabetes and hypertension. He's on low-dose aspirin and lisinopril. And when you see him, he has a tender, swollen, red left midfoot. So the question is, what are the things you should do at this point? Start colchicine 0.6 milligrams times 2 and then 1 later, and increase and continue it for up to 2 to 3 days, or start indomethacin 50 milligrams TID and then taper it over a few days. B, tell him to stop his aspirin. C, start him on allopurinol 300 milligrams per day. D, have him get a serum uric acid level, serum creatinine, and HLA-B5801 gene testing. And E, tell him to eliminate red meat from his diet. Now, some of my answers might be a little different than other people, but I'll explain as I go here. These are the answers I would give for this. I would start colchicine or indomethacin to treat this acute gout flare. And again, try to treat until the symptoms are all gone if you can. I would not tell him to stop his aspirin. It is true that aspirin raises uric acid levels a little bit. But my thinking is it's not necessary to control his uric acid that he stop his aspirin. And if he's on it for a good reason, then I don't tell them to stop. C, start him on allopurinol 300 per day. No, again, he should be on allopurinol, but I would put him on 100 milligrams per day and then titrate it up when it's time to take the allopurinol. D, have him get a serum uric acid level. Remember, he hasn't had one for 2 years. We don't know what his serum uric acid is. A creatinine and a B5801 gene. So definitely do that. He's Han Chinese. It's important to check the B5801. Most people won't be positive, but I see people who do come back positive, and I'm glad I checked, and those people don't go on allopurinol. Tell him to eliminate red meat from his diet. Again, a lot of doctors would probably say, yeah, eliminate red meat. My feeling is you don't have to be drastic about things like this. I think a modest amount of red meat is probably fine as long as he's on the right treatment for his hyperuricemia. One thing I would mention about this, by the way, if you're trying to convince your patients to stay on urate lowering treatment or an allopurinol long term, it can be helpful to let them know that at some point, not that long from now, they won't have any crystals in their joints anymore and they can't get gout. And that means that they can eat anything they want without worrying about getting a gout attack. So that, to some people, I think is a an encouragement to try to go with the program. They don't want to have to stop eating things that they like. Okay, case 2, refractory gout. So this is a 57-year-old male who comes in with 2 recent gout attacks affecting the ankles, the left and the right. He's been on allopurinol, or he was given allopurinol, 300 milligrams daily, in the past year, but he had stopped it a few months ago, and then we restarted it when the flare occurred. He took indomethacin with the recent gout flare, but is still having ankle pain. He's got a history of CKD3 and hypertension. On exam, he's got a red and swollen midfoot and ankle. And his last serum uric acid was done 6 months ago, and it was 5.7. So the question is, what do you recommend now? And the options are stop indomethacin and start oral prednisone, 40 milligrams per day, and taper over about 10 days. Next, stop allopurinol, continue allopurinol, and start colchicine, 0.6 milligrams a day after the prednisone is completed. Increase allopurinol dose to 400 milligrams per day. Educate the patient that he needs to continue allopurinol long-term to eliminate gout flares. And the final option is repeat the serum uric acid in 3 weeks. In this case, I probably would have him stop indomethacin and start oral prednisone. I wouldn't say it's mandatory, but he's been on the indomethacin and he's not really been able to get rid of the gout attack. I think prednisone has a better chance of achieving that. And, using it for 7 to 10 days is safe enough. I think that it's worthwhile to get rid of the gout attack. Stop allopurinol? No, you don't want to stop allopurinol. Continue allopurinol and start daily colchicine after prednisone is completed. Yes, I would do that in the sense of you don't need allopurinol and colchicine you don't need colchicine and prednisone at the same time. But after the prednisone, you can use the colchicine as a kind of flare prophylaxis. Next option is increase allopurinol dose to 400 milligrams per day. Well, you don't really need to do that the way I think about this, because it looks like he had a uric acid checked when he was on 300 milligrams a few months ago, and it was 5.7. And that tells me that that's probably the dose he needs to be on. So you don't need to increase it, you just need him to take it, is all. It is, again, important to educate him that he needs to take the allopurinol long-term to eliminate gout flares, just like he takes his blood pressure medicine or his cholesterol medicine. And I do recommend repeating the serum uric acid in 3 weeks, again, just to make sure he's at target. All right, so those are just 2 fairly typical cases. And it's time for questions if you have any.
And thank you, Dr. Goldfien, for that presentation. I hope everybody enjoyed that and found it very informative. We can take questions at this time. I don't see any in the chat box. Oh, actually, sorry, I did just see one come through. So the first question is, did I understand correctly that for chronic management, we titrate allopurinol up by 100 milligrams every 2 to 3 weeks, if not at goal?
Yes. I think this is so important, and it's something that, I've talked with internists and family practitioners, other primary care providers over many years who feel perfectly comfortable treating people for cholesterol or for diabetes and using a target-oriented approach. You want the A1C to be less than 7, and if it's not, you make a change until it is. I think it's exactly the same with gout. So there's no particular reason to think that titrating the dose of allopurinol makes it more risky. I don't think the hypersensitivity reaction is at all tied to dose. So yes, increase it gradually. If someone has CKD4, you could start with 50, and it doesn't take more than 2 or 3 weeks to re-equilibrate sort of the level they're going to be at and to know if you have to increase it again. And you don't have to stop at 300. If it takes 400 or 500, it's just what you have to do.
Great. Next question we have is it recommended to check HLA-B 58.101 in a patient with only acute gout?
You could do it. So someone who's got acute gout, in my experience, uh, at some point they're going to be eligible or at least appropriate for urate lowering treatment. I mean, gout is somewhat of a progressive disease because over time more crystals accumulate. So if you wanted to do it, you could do it, but formally you don't need to do it unless you're going to give someone allopurinol. That's the time to do it. If you have it done ahead of time and you already know, then great. Um, but what I'm recommending is before starting allopurinol.
Okay, next question is, if someone is on chronic NSAIDs for other muscle pain, how does it change change management?
Um, well, so I guess I would say it might not change. Hmm. I wouldn't use that in place of urate lowering treatment, I guess is the best answer I can give you for that. Um, Suppressing inflammation with either colchicine or with NSAIDs can keep people from having gout attacks in the short run. But if unless they're completely controlled and don't get any gout attacks, I would still probably recommend having them on urate lowering treatment. And the NSAIDs can still be kind of a flare prophylaxis. So I wouldn't, for example, change them and put them on colchicine if they're on NSAIDs for something else and it's helping them. But it wouldn't dissuade me from using allopurinol if they were still getting some gout flares and had a high uric acid.
Okay, next question is, what is the effect of thiazide HCTZ on uric acid? Could this be the effect of hypertension as a comorbidity? I typically stop thiazide in patients presenting with gout.
I do agree with you actually with that. Thiazides do raise uric acid levels by interfering with renal excretion, sort of like aspirin does, and sort of like insulin resistance does. But unlike, let's say, the aspirin situation, I don't know if people are still using it for primary prevention, but thiazides, there are alternatives. So, I would take someone like that and I might put them on an ACE inhibitor or or a different drug and just not use the thiazide. So I agree with you. I would stop the thiazide and use a different treatment for the hypertension. The connection between hypertension and gout may not be direct otherwise, like the connection between CKD or diabetes. It may be actually at least partly mediated through other comorbidities that people with hypertension have.
Okay, next question. Looks like we have a few in the chat. First one, if doing daily colchicine for prevention daily, is this in addition to allopurinol?
Yes. So during the first 6 to 12 months of allopurinol treatment, let's say you get someone to their urate target, studies show that these patients will still, at some rate, have gout attacks for up to a year, um, and that using the colchicine daily reduces the frequency of gout attacks in at least a statistically significant way. So yes, there's no substitute for the urate lowering treatment with allopurinol. It's just a matter of trying to keep them from having, unnecessary gout attacks until they're essentially cured at some point.
Okay. Last question I'm seeing is, they said, so during initial gout flare, treat with colchicine until flare resolved, and then start allopurinol once the flare is resolved.
You can do it that way. My practice has been if someone's had several gout attacks or recurrent attacks and I know they're appropriate for allopurinol, I actually don't tell them to wait. Um, it's sort of been a tradition to wait until everything's calmed down before either checking the uric acid or starting the allopurinol. Um, one but I don't think it's necessary to do that. And one of the disadvantages of putting off testing and treating is there is a real possibility that this patient will never come back because after their gout attack is gone, have remarkable ability to convince themselves they don't need to see you anymore. Um, And so if you can catch them and you've got them in the clinic when it's time to do it, sometimes that'll be your chance to start the long-term management program.
All right. I was just chuckling because I'm a nurse by trade for 6 years, and what you just said is so true. They never come back once their flare up is
Yeah.
Next question is, what would be the wider population other than Chinese, Korean, or Thai that you might test for HLA?
Um, you know, when I've looked at this, those are the three ethnicities that sort of are people tend to point to as having a higher rate of B20, B28O, B5801. Um, I might have to look it up and see if there are any others that I'm missing. Um, and again, the important thing here is that it is highly associated with this severe allergic reaction. And I guess although I'm not doing it consistently, I don't know that it would be a bad idea to check it in other patients. Um, our threshold for doing that may be a little higher than it needs to be for sort of optimal safety. So I'm not sure I remember any other ethnic groups in terms of that gene.
Okay, one more question. When would someone be considered to have chronic gout? For example, after how many attacks?
Yeah. You know, clearly this is a question of um, I don't think there's a right or wrong answer to this. A lot of people will say, if someone's had two attacks, you should start them on your rate lowering treatment. Um, Patients may not agree with that. Um, and I've seen some people argue for using urate lowering treatment for someone who's had even a single gout attack. Um, but I don't think there's any consensus on that. But it's really not something that there's a rule about. It's just a question of what your assessment is of whether they're going to keep having attacks. And, you might have to just take into account what the patient wants and give them a little leeway to, at least to start with. Um, so that if you end up deciding they should do it, at least they don't necessarily feel like you're railroading them into starting a long-term treatment.
Okay, I don't see any other questions. If anybody has any last minute questions, please feel free to type them in the Q&A box, or again, if you'd like to directly speak with Dr. Goldfien, you can request to unmute. Somebody just said, thank you for this excellent talk. So if there's no more questions, we are happy to give everyone 6 minutes back of their day. We appreciate everyone for joining, and again, our host at Bart's Altadonna for hosting today's session. And thank you, Dr. Goldfien, for your presentation.
Thank
Everyone have
you.
a good rest of your day.